It's Seabass, PGY5 Kidney Fellow. The fractional excretion of sodium is a useful test. FeNa is trash. That's hyperbolic. FeNa is a literal dumpster fire. Let's have a productive debate. FeNa Face Off. FeNa Face Off.
Kidney bathtub.
First up, let's do a quick review from medical school about what exactly the fractional excretion of sodium is measuring. The FeNa takes a look at the solute, which is excreted in the urine, and it compares it to the solute that's being filtered at the level of the glomerulus. In the case of a pre-renal acute kidney injury, this is typically mediated by decreased effective arterial volume, which means that we're going to see a decrease in the fractional excretion of sodium because the kidney's trying to hold on to as much solute as it can. The counterexample is going to be that of acute tubular necrosis, which is the most common type of intrarenal kidney injury. In this instance, the tubule would have been damaged enough that it cannot hold on to solute as it might otherwise do in a pre-renal injury. And so for an intrinsic injury, that solute will be dumped, leading to a higher fractional excretion of sodium. For the purposes of clinical applicability, you can whip out a calculator like MD Calc with an application on your phone to quickly compute what that number is. All you need is a urine creatinine, a urine sodium, and a basic metabolic panel. Next, let's take a look at the pro side of the argument. If you have fresh lemonade from a patient with AKI, then you should calculate a FeNa. It's not that expensive, it's decidedly non-invasive, and the turnaround time is typically pretty quick. Does the primary literature support this claim? Let's take a look at the evidence, straight from the primary literature in less than 2 minutes in a segment that I like to call Tick Tock Tickle Take. This particular article is a systematic review as well as a meta-analysis. The first thing that the authors did is that they searched a number of available databases that included Medline and the Cochrane Library for all studies that included their necessary criteria. The studies that were included were those studies that investigated the ability of the FeNa to differentiate different etiologies of AKI. The studies that were excluded were those that lacked sufficient data to be able to extract into a 2x2 table. Remember, a 2x2 table is one of those grids from medical school where you can basically calculate false positives, true positives, false negatives, etc. by essentially looking at the difference between an index test and a reference test. The authors then evaluated the methodologic quality of each of the studies in question and extracted the diagnostic accuracy data from each of those included studies. Finally, they completed a meta-analysis using a bivariate random effects model. They also did a subgroup analysis to look into sources of heterogeneity as well as the effect of relevant confounders on the accuracy of the FeNa. So what were the results? For the 15 studies, including 872 patients that used a FeNa threshold of 1%, pooled sensitivity for differentiating intrinsic from pre-renal AKI was 90% and specificity was 82%. In a subgroup of 6 studies, that's 511 patients, that included CKD or patients on diuretics, pooled sensitivity was 83% and specificity was 66%. In a subgroup of 8 studies with 264 patients that included oliguric patients with no history of CKD and no history of diuretic use, the pooled sensitivity was 95% and the specificity was 91%. The conclusion seems to be that the fractional excretion of sodium has decent performance when looking at the giant pooled estimates from all of the studies, but it does a swagnificent job with oliguric patients who don't have CKD or recent loop diuretic use. Now let's take a look at the con side of the argument. Here are 3 reasons why the juice is not worth the squeeze for FeNa. 1. The patient population in which the FeNa performs best is but a small fraction of all comers with acute kidney injury. For example, the specificity and sensitivity of FeNa is underwhelming for those patients who are non-oliguric. That is to say, they are peeing more than 500 milliliters in a day. Also, if the specter of glomerulonephritidity has been raised, or an acute obstructive process has not been ruled out, or even if the patient has chronic kidney disease, well, then you shouldn't be using the FeNa in those situations either. Ultimately, the sheer number of exclusions and exceptions limit the pragmatic applicability of this diagnostic tool. 2. The urine studies only shed light on how the kidneys are performing at a single point in time. Accordingly, FeNa that is obtained once and only once will sometimes miss the evolution of certain insults to the nephrons. 3. The FeNa propagates this false dichotomy of pre-renal AKI and ischemic ATN. It treats these two entities as if they are entirely separate, as if each of them exists in a vacuum. This is misleading. Sure, some patients have pure pre-renal AKI and others have isolated ATN, but many exist on a spectrum. For instance, a low FeNa can mislead clinicians into thinking that many of the nephrons in early sepsis-associated AKI are going to be responsive to volume administration, when in fact, many of those very nephrons may have already been victim to explicit tubular injury. If there's one thing I wish I knew as an intern, it's that pre-renal AKI and hemodynamically mediated ATN exist on a continuum. But the FeNa can often oversimplify this. It's like the DJ Khaled of AKI. It lacks nuance. Let's wrap up with a recap. Gray-haired attendings love to remind you that a careful history and physical examination are of the utmost importance. The thing is, for the initial consideration of etiologies of acute kidney injury, a careful history and physical examination are of the utmost importance. Beyond this initial subjective history, if the patient's already been given a reasonable bolus of isotonic volume, then the FeNa is not going to give you much, if any, additional information. After all, fluid responsiveness is the reference standard against which FeNa has been validated. If, however, you find yourself in a rare situation in which you have an undifferentiated AKI and the patient hasn't been given any volume yet, and the patient is also oliguric, and the patient doesn't have any exclusion criteria like chronic kidney disease or recent loop diuretic use, and you're worried enough about contributing to hypervolemia that you don't just want to give isotonic volume to see what happens, then, well, the fractional excretion of sodium can be really helpful. In fact, as we previously discussed, in this particular instance, the FeNa is exquisitely sensitive and specific. So what's the truth about the FeNa? I can give you my hot take. My entire first year of nephrology fellowship, out of the hundreds of acute kidney injury assessments and plans that I presented to attendings, I never once reported a fractional excretion of sodium value. Of course, there's selection bias with this because as a nephrology consultant, I only see a subset of all of the acute kidney injuries in the hospital. Additionally, underutilization of FeNa also happens to reflect the cultural practice of the institution in which I happen to be training. Ultimately, I think the jury's still out for the clinical utility of the FeNa. My sense is that it's dope for the boards, but meh for the wards. I want to hear what you have to think about this debate. Where do you stand? Let me know in the comments below. If you'd like to learn more with me in the future, smash the subscribe button. If you're asking yourself, Seabass, how do I gather other critical data points for working up the differential diagnosis of acute kidney injury? Well, then you're not going to want to miss this video right here. Thanks again. FeNa Face Off!